So looks like our numbers have stabilized a little bit. So again, welcome. I'm Liz Serrier and I'll be your facilitator today. I'd like to extend again a very warm welcome from IHME to each of you. Thank you so much for joining us for this session, which is GBD 2023, a closer look at non-fatal diseases, injuries, and risk factors. This is the third topic in our GBD 2023 in Focus series, in which we provide an overview of the GBD 2023 results, followed by a more in-depth look at each of the three capstone publications for this round. So today we have the distinct honor of having a panel of experts with us to explore this topic. So please allow me to tell you a little about each of our presenters, following which I will hand over the floor to our special guests. So, Dr. Liane Ong is a senior research scientist at IHME, where she heads the brain, back pain, musculoskeletal injuries, renal, respiratory, diabetes, drugs, dental, skin, and sensory team. I know it's a lot. She has worked on the Global Burden of Disease project since 2016, and her team is responsible for the global estimates of over 125 diseases, injuries, and risk factors. Prior to IHME, she worked at the U.S. Centers for Disease Control in foodborne disease epidemiology. Simon Hay is a professor in the Department of Health Metric Sciences and Director of Research Strategy at IHME. His career is focused on spatial and temporal aspects of infectious disease epidemiology to support the more rational implementation of disease control. As Director of Research Strategy, Professor Hay leads the strategic planning for research across IHME, primarily through developing an integrated portfolio of work that best presents the continued innovation and results of the Institute's annually produced global public goods. He guides IHME's geospatial research, leading work to identify common problems, solutions, and innovations in local disease burden and small area estimation. He also fosters strategic partnerships with intergovernmental organizations, government agencies, and other key user groups. Professor Hay obtained his doctorates from the University of Oxford, where he remains a member of Congregation. With us, we also have Dr. Michael Brauer, who is a professor in the School of Population and Public Health at the University of British Columbia, and an affiliate professor, principal research scientist, and environmental, occupational, and dietary risk factors team lead at IHME. Dr. Brauer received a doctorate in environmental health from Harvard University. His research focuses on linkages between the built environment and human health, with specific interests in the global health impacts of air pollution, the relationship between multiple exposures mediated by urban form and population health, and health impacts of a changing climate. He has participated in monitoring and epidemiological studies throughout the world and served on numerous committees, including those advising the World Health Organization, the Climate and Clean Air Coalition, the World Health Federation, the U.S. National Academies, the Royal Society of Canada, the International Joint Commission, and governments in North America and Asia. His contributions to environmental health have been recognized by a number of career achievement and publication awards. And so, now that I've told you a little bit about our esteemed panel today, so before I hand over to them, we'll just briefly review our agenda and some housekeeping, following which they will take it away. So today we'll spend about 35 minutes just looking at critical findings, following which we'll have a 20-minute, 15 to 20-minute question and answer segment where each of you will have the opportunity to pose any questions you have. Out of necessity today, our mics are muted, so we invite you to please use the Q&A function, which you'll see at the bottom of your screen, to ask any questions you have. So you can ask questions, put them in throughout the session, but we will address them all at the end. And of course, if you'd like to ask questions after the presentation is over, you can always email them to us at gbdsec@uw.edu. And again, the session will be recorded like the others and will be shared via the collaborator portal. And so with that, I will hand over to our presenters.
Okay, let me share my screen. And I would be grateful if someone could confirm that all is good. You can see the slide.
All is good. Yes, we can see.
Excellent. Well, welcome everybody. I'm going to lead off. Liane is going to then follow, and Mike is going to conclude for us. We all have about an equal amount of time, and I'm going to give the sort of introduction to how we make these estimates and the global burden of disease in general. Liane is going to look a little bit more closely about the disease and injuries, and Mike's going to have a look a little bit more about the risk factor results. So I'm going to go straight into it. We're obviously talking about GBD 2023 here, and this is the paper, which is open access on the paper that we're talking about today. It's open access, it's online, it's easy to find through the Lancet Global Burden of Disease specific webpage. It is your kind of quick guide to what we think are the most interesting results from this iteration of the capstones. It is quite a beast. It's large, you know, there are lots of results in there. It's intentionally that way. We've evolved it to be that way over the years. And there are also some very significant appendices that go with it that synthesize a lot more results. So we, of course, in this hour, can give you only a potted summary of what's in there and the techniques, but please do look into that in a lot of detail and of course the other capstones that are available in the same issue for more details on anything that we say today. I'm first going to introduce some of the metrics that we use and talk about some acronyms that you'll see pretty much throughout this entire talk. So this schematic goes through them in as simple way as we can. If you look at this first part of the diagram, it shows a baby moving into adulthood, and that is supposed to represent the amount of healthy life that someone lives. Then at some point in their life, and it can be early on or later on, and for the purposes of this schematic, we put disease and disability at the next stage. And then of course, most people will spend some of their lifespan with a disease or a disability from all the myriad different causes that you can imagine. And we want to capture that whole spectrum and be able to present that as one metric for you to use, which we'll call the DALI, and I'll explain that in just a moment. So from disease and disability, we get a duration of life, years of life lived with disease, which is the first part here. And that is estimated from the prevalence of that particular condition times a disease weight, a disability weight, I beg your pardon. Those disability weights are on a scale of 0 to 1, with 0 being perfect health, to the equivalent of perfect health, and 1 being death. And those disability weights were gathered and have been gathered over a series of surveys, testing many hundreds of thousands of individuals and their assessments of how severe on that spectrum was a particular disease or condition. Those are then put together and give us our YLDs. We then have the last section, which is before you reach the known, or the not known, the population expected life expectancy of a particular group. You can have a death, and then we can calculate the years of life lost, which is at the point of death, how long were you expected to live if you go to the average of one of the most healthy populations on Earth. So then you add the YLD and the YL, which is the disease and disability part, plus the mortality part, and you get the DALYs. Disability adjusted life years, and that is a comprehensive method or metric of burden that includes disease and disability and death. You will hear, as we go through this talk, most conversations about DALYs, but we may slip into using YLDs and YLLs, which is why we cover that first. This, of course, is in excruciating detail in all of our trainings, all of the myriad references that you can find to the GBD over time, and is really the unifying metric of a lot of our work. So worth putting a little bit of effort into thinking exactly how that works for individuals and populations. A little bit of history of GBD. I can't go into this in fantastic amount of detail, but I'm going to go through those and highlight that essentially as we go through time, more and more people have joined the GBD process in terms of both its estimation and its collaborated group. We have got more and more complexity in terms of the diseases and injuries that we cover, the regions and subnational aggregation or disaggregation of those data, now to very, very up to admin1 spatial resolutions in all of the largest population states of the Earth, the differentiation between age group types, and the time or time series for which it's estimated. So the first one came out, published by Christopher Murray and Alan Lopez way back in 1996, when they were both at the World Bank. The next one, in collaboration with WHO, you can see increased the number of disease and injuries they looked at, diversified the number of regions, and looked further into different time points. And I think those 4 time points there were the year 2000 to the year 2004. As we move to IHME, the sort of center of gravity moving from the WHO collaboration to the Institute of Health Metrics and Evaluation here in Seattle, we've gone through 1, 2, 3, 4 iterations of the GBD, and at the end of that process are dealing with more than 300 diseases and injuries, over 195 countries and territories, 20 age groups, and 6 time points. As you can see, just more and more complexity in each iteration, and we'll go into describe a very little bit of that in this section, and then much more of that in terms of the results. As we move to the 2017, 19, and 2021 iterations, still here at IHME in Seattle, we have again increased the diseases and injuries, increased the number of countries, increased the number of age groups, adding older age groups more and more. But the big change there was estimating the whole time series from 1990 by every year all the way through to the present day. And this is what we're talking about today, the 2023 version of the GBD, 375 disease and injuries, that number of countries and territories and age groups, and all years from 1990. The reason that we're on 2023, and that has a particular iteration, and we were slowed down from GBD 2021 is COVID. I won't go into that in a great deal of detail, but this is the first GBD iteration since that time. We believe gives us a good look at health metrics across the world post-COVID, or the first good look at metrics post-COVID globally. GBD 2025 is already ongoing. These are iterative processes, and the whole of the GBD is re-estimated under every iteration. The reason for that is that we can often find data back in time, which improves old estimates, and that will, of course, affect the whole time series. So methods can also change in that period and be updated and improved. So each iteration of the GBD that gets released and gets released to the various funding organizations, gets released to countries, gets released to our collaborating network, and gets released to on a now a shared basis to anyone who wants to use these data, gets a full re-estimated GBD in every iteration. I'm not going to read out that again because you've heard of all of that, but it's from 1990 to 2023, and the new bit there is it's determined by male and female disaggregation as well. And for each of those metrics, for each of the types of diseases, age groups, years, we produce a prevalence and incidence. We produce the years lived with disability, which I just explained in the first slide, quantifying all the aspects of non-fatal health loss, the years of life lost, quantifying the fatal health loss, adding those together and getting the disability adjusted life years, so a combined metric of all burden. We also calculate something called the healthy life expectancy, which is for the average human in the population studied, how many years of life we expect you to lead in good health, i.e. without a disease or injury. We estimate as counts and rates. So a count would be the total number of a particular disease you've got in a time period. The rate will be that divided by the denominator, which has a population number in it. And we do that all age standardized and age specific. I won't go into those a lot of detail there. Here, we just don't have time to do that. One of the things that people always and quite rightly want to know about the GBD is how much information is used to predict these models. And one thing that is perhaps not so observed from the outside is that we put a fantastic amount of effort across IHME and across the collaborator network to get as many GBD data sources as we can on prevalence, incidence, remission, severity, and the mortality associated with each disease and injury. And some real numbers here are DALYs were informed by, as you can see, 120,000 data sources, 35,000, I beg your pardon, of them new for this iteration. I am having trouble forwarding. Why is that? I beg your pardon, everyone. I'm not quite sure why that happened. Let me get back to where we were. There we go. I'm not sure what I did there. So the DALYs were informed by 120,000 data sources, 35,000 of those new in GBD 2023. As a reminder, they can be new as in new data at the end of a particular year. So they might have been data for 2023, for example, but they can also be data, new data that we found in the year 2000, which goes to improve those predictions back in that time. Because remember, we do redo those estimates for all of the time series. There's, you can see a breakdown here for the numbers by incidence and prevalence. And we can see the attributable burden was informed by almost 60,000 data sources, including 16,000 new. These are more of the risk factor side, so 55,000 of those. 4,000 sources on the magnitude of causal impact of a risk to an outcome. And the most important thing to get from this slide and to understand from GBD gather compliance is that all of these data are indexed in the Global Burden of Disease Study GHDX tool, where we are allowed to make those, share those information with people. Those are usually available. In many cases, they are not. And that is because we're honoring the, we don't add any extra restrictions ourselves, but we honor the memorandums of understanding which we have with particular governments or agencies, or in some cases, individuals that give us those information to contribute to the GBD. But as much as possible, we make available what has come in, and all of those efforts that we put into standardizing and putting that data into a consistent format for estimation. I am going to race through the number of sources here because we talked about those before. 35,000 new diseases and injuries, 16,000 for the risk factors. Of new causes, there are these: ulcerative colitis, Crohn's disease, thyroid diseases, other endocrine, metabolic, blood and immune disorders, and electrocution. There are 50 new risk outcome pairs, and we removed a temporary fix that we had for other pandemic-related outcomes, and have essentially incorporated COVID in a much more elegant fashion in the process. For some of the methods, and I can't go into this in a lot of detail, but maybe just to highlight that this is a transition that will be going more and more into GBD 2025, is we've moved from one type of disease modeling, MR, to a more impressive disease modeling system that helps us basically look at the time series and cohort relationships of disease modeling in a much better way than we've done in the past. All of that for a future time, but just to know that diabetes, or type 1 diabetes, major depressive order, anxiety, and autism spectrum were done in that new way in this iteration. And there are lots of other methodological improvements that we don't really have time to look at in a huge amount of detail, but are part of the ongoing activities here at IHME and what many people spend their hours and hours and hours deliberating and testing and improving in each iteration. This, if you do any of our trainings, which I advise, and you may already have done, if you read any of our capstones, you read any of the appendices that go in, you will see these types of diagrams explaining how the process works. I am not going to go into every piece of this, but essentially draw your attention to the fact that different pieces of this process come together. The finding information from the literature, getting prevalence, moving it through DISMOD, taking the prevalences and adding those together to get our YLDs, coming in from YLLs, making DALIs, etc., etc., so that you can go to any level of detail that you want to understand this particular process. But I haven't got time to do that here. So I am going to move on at this point, hand you over to Dr. Liane Ong, who is going to go through many of the selection of the results for disease and injuries. Thank you, Liane.
Thanks, Simon. Just a moment. Okay. Can everyone see my screen okay?
Yes.
I can.
Okay, perfect. Okay. Thanks, Simon. And thanks everyone for joining us today to hear about more information about the capstone. So I just wanted to give a little bit of a summary of GBD 2023 results. But before I get in depth, I just want to reiterate what Simon mentioned, which is this information is summarized in GBD publications. There will also be a series of topic-specific papers, some written by individuals at IHME, some written by collaborators such as yourself, to kind of highlight and focus on specific disease and injury areas as well, or risk factors. You can explore all of the information that we are talking about, but also for your countries or age groups or populations that you are particularly interested in. So we have a visualization tool called GBD Compare, and here is the website to it, so you can explore. There's, if I remember correctly, there's over 2 billion for estimates that we produce. So there's far more than we can talk about today. So we leave it to you to explore this tool and kind of have fun with it. We also make the estimates available to be downloaded in the GBD results tool. So here again is the website for the link for the to generate and to download that information. So just to kind of just let you know that in order to be able to download those results, you will need to create an account, and that is free, and a login just to access the data. And so if you have any concerns or any issues, you're more than welcome to reach out to the GBD Secretariat. Sometimes there are technological issues and that we might need to help you resolve. Okay, so we wanted to talk very, very high level about some of the major findings and the results that we're seeing. So when we look at this is a tree map, and what this is every box represents a different level 3 condition. So GBD is structured in a hierarchical fashion with subsequently more granular diseases. So this is level 3. And what this is showing is each box is the size of the burden and prevalence. So if you took the outer edges of this box, that would be the total number of individuals with a prevalent disease in the world in 2023 for both sex, all ages. So what you can see here is that some boxes are quite large and some boxes are quite small. And when we look at this in prevalence space, we see that there are two quite very large boxes, and the most prevalent level 3 causes are oral disorders. That's made up of 5 distinct oral conditions. So deciduous caries, permanent caries, edentulism, periodontal disease, for example, is in this grouping. And then the other very, very prevalent condition is headaches. And this includes tension type headaches and migraines. So when we look in prevalence space, and this is just the number of people who experience these conditions, these two are extremely prevalent in the population. I'm going to take this opportunity to also plug that this month, GBD will be publishing a GBD 2023 headaches paper. So if you want far more details about headaches, please look forward to that paper. It will be published in the Lancet Neurology, I think next week. So just in contrast, when you look at this tree map, we have another tree map where this is for DALYs. And so this is actually for level 3 in DALY's space. You can see that the shapes and the sizes of these boxes look quite a bit different than in prevalent space. Now, DALYs, as Simon was mentioning earlier, incorporates YLLs and YLDs. So you're accounting for both severity of the condition, premature mortality, and so you can see different shapes because no one dies from oral disorders and no one dies from headaches. So in this case, the 3 most burdensome conditions are ischemic heart disease, neonatal disorders, and stroke. And so I just wanted to highlight that you'll notice that stroke and IHD are in red, and then in green is neonatal disorders, because most of this fraction of DALYs that's driving this large box of neonatal disorders is actually YLLs. So that is really getting at the fact that in early life, many of these children in areas of the world are dying very, very early. And so they have lost a lot of early life. Now, this is at the global level. If you were to look at this tree map in certain parts of the world, this share of neonatal disorders is going to be quite small because neonatal disorders is not as large of a problem in those areas. So I think this is some of the nuance that you can get in these visualizations in GBD Compare that I encourage you all to look at. The other thing to flag is that non-communicable diseases, which is this blue box collectively, now account for nearly 2/3 of the global DALYs. So sometimes what we like to show you is what this tree map looked like in 1990. And in that time period, this red box, which are your communicable diseases, was much larger. And so what we're seeing is a shifting into non-communicable diseases globally as a share of the larger burden, health burden. Okay, so the next thing I want to talk about is just how this distribution of global DALYs across age and sex is for level 2 causes in GB 2023. So on the what this graph is showing is on the x-axis is age, the top graph is showing females, the bottom graph is showing males. And these are level 2 conditions, so it's a one step up on the hierarchy. And in red are your communicable maternal neonatal diseases. In blue are your NCDs, and then in green are your injuries. And so this is in 2023. And what we can see here is that where in the population non-communicable diseases are affecting the largest group. And we see this in middle to later life. And these are things driven by Alzheimer's and low back pain and headaches. Diabetes, for example, is in this group. But when you look at in very, very young ages, those communicable maternal neonatal diseases are actually still driving the fraction of DALYs. And so again, this will look different based on where in the world you're looking, but this is a global picture. So just to put into perspective, the amount of DALYs for males or females are about the same, 1.5 billion. And then the share of DALYs actually peaks in the 65 to 69 years of age. And I think this definitely goes to show about this shifting to the non-communicable diseases, the burden of these age-related diseases, and how significant they are in these older populations. And so the other graph I want to show you is the leading level 3 causes. And here you can see this shift. So this is the top 25 conditions at any time point in 1990, 2000, 2010, and 2023. And you can see this shift over time. And so on the far right, this is a figure in the capstone. You can see the number of DALYs in 2023, the percentage change between 2010 to 2023, and then the percentage change in age standardized space to account for population structure. So just to flag that what we've noticed is some notable decreases since 2010. Diarrheal diseases has decreased by nearly 50%, HIV/AIDS by 43%, TB by 42%, malaria by 21%, and then neonatal disorders by 16%. Much of this is driving in the YLL space. So and I think it's a really demonstration of the success of many interventions and policies that many countries where this was a significant problem, in 2010 have made huge strides in improving. So we're able to keep people alive longer or prevent the occurrence of disease. So, and just reiterating that these leading causes are now dominated by NCDs, and you can see this shift in the color, right? So each of these colors, red for maternal, neonatal, and communicable diseases, blue, in this case, it looks kind of purple for non-communicable diseases, and then green for injuries, is a way to kind of look at this as how the shifting of red to purple or blue has happened over time. I think it's also very much worth noting that the injuries really haven't shifted. So, I think from a policy perspective or just on a local level of seeing great strides in communicable diseases, kind of this shifting to non-communicable diseases and what happens, but really we don't see much change in the injury space, which for conditions that policies oftentimes have a direct and more immediate impact, it's a little bit something worth looking into and understanding. Okay, so risk factors, and I'm going to let shift this over to Mike.
Okay, thank you. And I'm going to do the sharing. Let me just try my sharing again. There we go. So I'm going to do a very quick overview of some risk factors, just starting out very, very high level. And I think really an important aspect that was called out in the capstone paper is that over half of global health loss, so over half of the DALYs, is attributable to known risk factors. So this is basically suggests a large potential for reduction in health loss by addressing these risk factors. And what I'll cover is really some of the progress that's been made on risk factors, as well as some of the trends that are concerning for risk factor exposure that is worsening. You can see in the top figure that the risk factors that we've categorized at the very highest level, behavioral risk factors, are the leading contributor to DALYs. Those are trending downwards. As similarly for environmental and occupational risk, those are also trending downwards. But concerning is that if you look at overall DALYs as well as age standardized rates, so now adjusting for changes in population size and population age structure, that we have a flattening of the trend for metabolic risk factors. So meaning that we're really not making sufficient progress, especially accounting for changes in age structure and population. And we'll do a little bit more of a deeper dive into that. This is now the same tree map, actually, that Liane just showed. And what I'm showing here is that the darker shading is the proportion of each of these boxes, so each of these diseases or injuries that are attributable to risk factors. So for example, if you look at something like ischemic heart disease, so a leading cause of disease globally, the darker shading really covers the entire box or nearly all of the box, meaning that we're accounting for nearly all of the disease in terms of attributing it to specific risk factors. You can see similarly for chronic kidney disease, diabetes, stroke, for example. So this again shows the potential for addressing risk factors as a way to reduce the burden from these particular diseases. On the other hand, I'll just point out some rather large boxes, especially things related to mental health or musculoskeletal disorders or back pain. So these are large contributors to disease burden, and we actually have very poor risk factor attribution. So we're actually not accounting for a large proportion of these diseases through modifiable risk factors. So one can argue that we need more research to try and identify potentially modifiable risk factors, for example, for things like major depressive disorder and anxiety. So now this is looking again at a very similar plot as was shown for diseases, and we're looking at the trends in the leading level 3 causes of disability adjusted life years and their attribution to the different risk factors. So a few things that I will point out are the leading risk factors contributing to disease burden. But what I want to stress on this slide is really the trends. You can see, for example, for systolic blood pressure, particulate matter, and let's say smoking as examples, that we are seeing, for example, with systolic blood pressure, increase in the total number of disability-adjusted life years over the period 2010 to 2023. But when we adjust for population growth and population age structure, so the age standardized daily rate, we actually are seeing a decrease. So this is really two sides of the same issue. Overall increase in numbers, but actually the rate is decreasing if we adjust for age. What it suggests, however, is since the overall number of DALYs are increasing, that our risk factor reduction is not really sufficient to keep up with the aging population. So this is a very similar picture for smoking. Now, if you look across this final column here, so again, age standardized disability adjusted life year rates, every single one of these major risk factors, we have a decrease. So we're seeing a drop when we adjust for age structure, with three exceptions. And the three exceptions are an increase in high fasted plasma glucose, BMI, and drug use. What this means is that these are essentially double whammies in the fact that not only are the overall numbers of disability-adjusted life years attributable to these risk factors increasing, but it's still going up even after we account for population growth and changes in the age structure, essentially population aging. So it's very important to, and both of those sort of have different policy implications. I do want to point out some real positive trends. When we look compared to 2010, we see very large decreases, especially for child growth failure, for smoking, unsafe water, unsafe sanitation, and access to hand washing. And then I pointed out these worrisome increases, however, for fasting plasma glucose, high BMI, and drug use. I don't have time to go into any of this in a lot of detail, but just again, want to urge you to look at GBD Compare, where you can look, for example, at not only how these risk factors vary geographically, but even how the rates of change are varying geographically around the world. You can see, for example, that throughout much of the world, and especially throughout most of Asia, Africa, parts of North America and South America, we have high systolic blood pressure, of quite a different story, for example, like of particulate matter air pollution. I'll point out that this is combining both outdoor air pollution or ambient particulate matter as well as household air pollution. Those also have different patterns, but you can see again here, North Africa, the Middle East, and South and East Asia, especially affected by particulate matter air pollution. Smoking, very much a situation of throughout Asia and Eastern and Central Europe, as well as to some extent parts of the Middle East. High fasting plasma glucose, again, quite a different geographic pattern. You see, for example, the very high risk attribution in, for example, in Mexico. So again, these are just to highlight the depth of the information that you have. I don't really have time to sort of go into all of the details here. I will just highlight looking at high BMI. You can see that this is actually spanning throughout much of the globe. There's actually more regions that have very high risks attributable to high BMI than do not. And as I mentioned earlier, this is one of those trends where we're actually seeing increases throughout all the regions. So you can see over time, just separated by World Bank income levels, we have increasing trends in attributable burden to BMI in all regions of the world. In this figure, the countries in orange are red. High BMI is responsible for more than 10% of the overall burden. We've also, as we do in every cycle of the GBD, made some methodologic changes, and one of the ones with major implications is including new evidence on the relationship between lead and cardiovascular disease. And as a result of this, lead is now the 9th highest risk factor for DALYs the 10th leading risk factor, and it accounts for up to 9% of DALYs in some countries. This is, again, not driven by the well-known impact of lead on intellectual disability and IQ loss in children, but the effect of lead on cardiovascular disease that's mostly affecting adults. This is a bit of a teaser. We're now at IHME doing a lot of work on climate change and future climate warming. Since GBD 2019, we have always included warm temperatures or high temperatures as a risk factor. And what you can see, especially in lower middle income countries, we're seeing an increase in high temperature attributable burden. Overall, globally, we have around 600,000 deaths in 2023 attributable to warm temperatures. I'll also point out on the right-hand side here that broken down by causes, there's really some very intriguing and interesting patterns. For example, you see in the young adulthood, for example, we're seeing high impact of warm temperatures on things like injuries, traffic injuries, other injuries, self-harm, and violence. In younger ages on infections, and in older ages on NCDs. Our work on climate is now taking this kind of information and projecting it into the future under different climate scenarios to 2100. So just to close out some overall takeaway messages from this capstone, importantly, as I've already mentioned, nearly half of global health loss in 2023 was preventable through modifiable risk factors that we've identified. And those top 5 risks have not changed dramatically from previous capstones. High systolic blood pressure, particulate matter, air pollution, smoking, high fasting plasma glucose, and low birth weight and short gestation. So increasing healthy diets, physical activity, tobacco control, and improving air quality, actions against those risk factors could dramatically reduce global health loss. The progress that has clearly been made on communicable maternal neonatal nutritional diseases has increased, but we believe it is fragile. So we've seen this decrease. It has continued, especially related to diarrheal disease, HIV, tuberculosis, malaria. It still remains high in the low STI, low income countries, especially in sub-Saharan Africa. And there is a concern about recent cuts in health funding threatening to reverse some of these gains. And that really remains to be seen how that will play out, something that we're putting a lot of attention on for the next cycle in the GBD. The overall burden of NCDs and metabolic risks especially are rising. NCDs now account for nearly 2/3 of global DALYs. And as has already been said, those due to metabolic risks rose dramatically since 2010, especially related to high BMI and high fasting plasma glucose. We also see increases in mental disorders. That's rising globally, and especially in younger individuals. So as an overall message, health systems must continue and transition even more quickly to NCD prevention, early diagnosis, chronic disease management, and certainly begin addressing this large increase that we're seeing in mental disorder burden, especially for younger individuals. As always, we are faced with a challenge of limited data, especially in some locations where the burden is greatest. And we work together with all of our collaborators to try and acquire and secure new epidemiologic data as well as new survey data, again, challenged by some cuts in global health. And I will also just point out the last bullet point here that we are also now actively engaged in forecasting disease burden under reference and alternative risk exposure scenarios. And this is a very high priority at IHME for all of our work. So I will just close there and invite you in the remaining time that we have to submit your questions using the Q&A function. Thank you.
Great. Thank you so much, Dr. Brauer, Dr. Ong, and Dr. Hay, and also to our guests that are with us, our audience. Thank you so much. We see the emojis floating up on the screen, so thank you for sharing those reactions with us. As yet, we'd just like to encourage you again to please put any questions that you have using the Q&A function. And while we wait for some more questions to come in, I'll just ask a question of all three panelists here. And it's, were there in your areas any unexpected or outlier results, and how did you account for those? I'll just throw it out so anybody who wants to jump in is free to do so.
I don't think that anything was like, where we thought it was going to increase and it didn't decrease. I think some of it was, a little bit of disappointment and the fact that some trends have remained stable when we would hope that things would maybe decrease. I think that, oftentimes, at least on my team, when we're modeling, we are going to approach it with our own like hopes for the future or hopes for populations, and then to see that the data doesn't really express that, and it's a little bit, I think it's surprising and disappointing, but not in something where like we think we did something wrong. Let's put it that way.
Mm-hmm. Mm-hmm.
I'll
Right,
just
excellent.
offer a few. I wouldn't call these sort of outliers, but a major theme that is really that we've gone through the pandemic and the sort of inertia in the health improvements that we've seen historically have continued. We hope that continues. And again, I've sort of mentioned that, global health funding is challenged. So there's another challenge overall that we're faced. But so far, it appears as though we've gotten through the pandemic. I would say on the sort of negative side, this impact of what have been called sort of diseases of despair amongst youth, and the focus of some of the risk factors that are increasing. So both the metabolic, so high BMI, but also drug use and the relationships between all of those together, I guess, has challenges for the future. And then finally, in the area that I work on, in mostly focusing on the dietary and the environmental risks, I am surprised by the magnitude of the impact of lead when we made this change. So this is a risk factor that we've known about actually for several thousand years. And the fact that today it is responsible for around 3.5 million deaths is, I think, staggering and really requires attention.
Thank you so much. Dr. Hay, please go ahead.
So from my side, the surprising thing wasn't any particular disease, but the clusters of them, a bit echoing what Mike has said. I mean, that's spectacular success in childhood and maternal health improvements over the period of observation, I think really does need to be put into context, and the world really realize a little bit more about how massively important that was, is, and should be ongoing. And the fact that all of those diseases that malaria, HIV, TB, all of those diseases that contribute a huge amount to that are very amenable to rebound and resurgence. So we have to take very seriously many of the geopolitical changes that are going on at the moment, and that those gains are very fragile. They're spectacular and fragile. And the other bit that surprises me, again, similar to Mike's observation, is quite how dominant the NCDs are in our world. And that's cosmopolitan in the sense that it's everywhere across all countries, obviously to different rates, and each country has their own unique set of problems there. But as a world and as a community, that is one of the biggest challenges or opportunities, if you like, of where we can make impacts into people's health and longevity in the remainder of our lifetimes and our children's. So I'll leave it there.
Thank you all so much for those insightful responses to that question. We are at time, but we have one more question in the Q&A that I think that we will try to address. And so question comes from Marita Cross, who says, I may have misunderstood, but were diabetes, major depressive disorders, etc., modeled within this capstone under DISMOD AT rather than MR 2.0, or is that future work?
Type 1 diabetes was modeled in DISMOD AT. Total diabetes was not. We tested it. It didn't quite make it in. But in GB 2025, it will be.
Okay, great. Thank you so much for that response and that clarification. I think with that, we're slightly over time, but with that, I would like to extend again, great thanks to you, the Collaborator Network, our audience, for joining us today, as well as even great thanks to our Dr. Hay, Dr. Brauer, and Dr. Ong for being with us during this presentation to just shed some light on the capstones and present this opportunity for asking questions and, direct interaction about the disease, injuries, and risk factors capstone. And so we look forward to continuing our work with the Collaborator Network, because indeed what we do would not be possible without you. And so thank you again for your continued work with us and for joining us today. I wish every single person here a fantastic rest of your day. Thank you.